One of the things is that the US FDA approved agents, anti-craving agents, are naltrexone and acamprosate. BACLOFEN is so far not a US FDA approved, and there is the aversive or the deterrent agent DISULFIRAM. Since it's also a commonly prescribed agent, we'll discuss briefly about it. Yeah, so this just shows the mechanism of naltrexone. So it's an opioid receptor antagonist. So when alcohol and any other substance, one of the mechanisms by which there is the feeling of pleasure is the release of endogenous opioid. So naltrexone is an opioid antagonist receptor, and so it actually blocks the opioid receptors. This person will not get a pleasure high in toxic pleasure or high with the alcohol use. So this is the mechanism of action of naltrexone. So the dosage for alcohol use is 50 mg to 100 mg, generally administered in the morning. Different forms of naltrexone are actually currently available. I mean, what we use is oral, but then also nowadays injectable naltrexone as well as implants are also available, but prohibitively expensive. So one of the things with naltrexone, when you do prescribe it, is even the oral naltrexone tablets, one tablet based on the brand 50 mg tablets is somewhere between 55 to 65 rupees. So it's really very expensive. So that's something that needs to be discussed with the client before you start. So what kind of patient profile is naltrexone effective in someone with early onset alcohol dependence? It is someone who has alcohol dependence before 25 years of age, someone who complains of excessive craving, family history of addiction. So naltrexone is one of the drugs for which a lot of pharmacogenomic studies have been done, and there is a specific gene polymorphism related to OPRM1 gene, and people who have polymorphisms in the specific gene seem to actually respond to naltrexone much better. So hence the family history of addiction. Wants to be a social drinker. So I mean, naltrexone is an anti-craving. You can actually use alcohol even when you do use naltrexone. So somebody who does not want to remain completely abstinent, want to have reduced use of alcohol or use alcohol once on an occasion on weekends, this would be a good agent. In someone with binge drinking is there is excessive drinking for a very short period of time followed by a period of abstinence. So somebody, and then maybe useful on the days when drinking is anticipated. So it's a very popular method called Simpson's method. So what we do use in somebody who may be using in the weekends, but it's becoming excessive, you probably give him 50 mg naltrexone maybe 1 or 2 hours before he actually goes out, so that hopefully it reduces the amount of alcohol that the person uses. These are the various patient profiles that you will use it for. So, but what are the side effects? I mean, one of the common side effects, please do a LFT before you start naltrexone, and repeat the LFT every 3 months. There is elevation of liver transaminases. Now, the importance of the liver transaminase, mainly I refer to the SGOT and the SGPT. How important they are, how does it actually translate into liver pathology or something serious is this thing. It is fairly safe, actually. It is fairly safe, but just do. One of the very common and important side effects are GI side effects. These are very significant. Nausea, vomiting, diarrhea, abdominal pain, reduced appetite is what a lot of people actually complain about. So these are very important symptoms. This is on many occasions one of the reasons for discontinuing the drug. So this is something that you must discuss with your client before starting that. And the other very important, since they act on the opioid receptors, so the endogenous opioids are responsible for the internal motivational drive. So there is a reduction in the motivational drive because of that non-specific low mood, some dysphoria, anxiety. These are all important side effects that may be. So there must be caution when you actually are prescribing for someone with comorbid depression. So these are things that you must be aware of. There should be a precaution in people with any kind of chronic pain syndrome. So one example that you would come across is someone with alcohol dependence and chronic pancreatitis. The issue is only that naltrexone, since it's an opioid receptor antagonist, it will block all the receptors. And if there is any instance of an acute exacerbation of the pancreatitis, the pain will have to be managed with opioids, and they will not work because naltrexone is there in all the receptors. So this is the major issue. It can also have various kinds of sexual side effects with reduced libido, delayed. These are sexual side effects are also sometimes complained with naltrexone. But the major ones are probably do an LFT. The GI side effects are the immediate side effects with which you probably may have to actually require, because in some people it reduces the appetite significantly. And non-specific low mood dysphoria, those are things that you need to actually actively ask for and tell your patient, and that is something also that needs to be looked at. Acamprosate is a glutamatergic receptor antagonist. So the dosages in people who are weighing more than 60 kilograms is 300. So the tablet formulation is 333 mg, 222. In people who weigh more than 60 kilograms and less than 60, it's 211. The thing with acamprosate, as in naltrexone, you can start prescribing the agent at the time of detoxification. You can immediately taper it off as well. Again, acamprosate is a structural analog of the amino acid taurine. It's an extremely safe drug because of that. So some of the immediate side effects because of taurine, there will be some amount of osmotic absorption of water. There may be some diarrhea, abdominal pain. So some GI side effects are the major this thing. Apart from that, it's an extremely safe drug. The only thing is that acamprosate is majorly actually excreted to the kidney. So you need to find out whether there's some renal impairment, whether there are renal conditions. So that is something that you need to ask for. Acamprosate can be given, since it has predominantly more 80% renal excretion. It can be given in people with chronic liver disease as well. So it's an agent that can be used. So it works in someone with later onset ADS. Since it is a glutamatergic receptor antagonist, for someone with protracted withdrawal, it can have some use. It is best used in patients who actually aim for complete abstinence. It's safer compared with naltrexone in patients with hepatic impairment, as well as with people with multiple medical issues. Because since it's a amino acid analog, there aren't any drug interactions. And this thing, the only major medical issue that we need to be worried about is renal dysfunction, and can be started along with benzodiazepine detoxification. So baclofen, popular agent, something that we also use very commonly over here. We generally give somewhere between 40 mg to 60 mg in most of our patients. Initially, when baclofen was initially introduced, it was actually used in people with advanced liver disease. However, at lower doses, somewhere around 30 mg is the dose. Most recently, so in February 2018, a recent meta-analysis for baclofen. So what does the evidence show? Because it's not an FDA-approved agent. So in 2018, actually, the first meta-analysis for baclofen has come out. So what it says is baclofen is definitely associated with higher rates of abstinence compared to placebo. However, probably there is no superior effect of baclofen on increasing the number of abstinent days or heavy drinking days. And probably there was earlier one of the indications for baclofen that, comorbid anxiety, since it has GABA reaction, there might be some action. I mean, in people with more of anxiety, depression, there doesn't seem to be any superior effect compared to other agents. The thing with baclofen, it does seem to be more effective. There needs to be probably better studies with better power, with more number of people to actually evaluate its efficacy. Clinical experience wise, it does seem to be a very good agent which reduces, at least in our personal experience, it seems to be the agent which reduces craving for alcohol the fastest, probably because it's a GABA B agonist. But then you should be aware of the most. And the side effects are something that needs to be asked. Headache is something that a lot of people complained about. Drowsiness, and hence there should be precaution while driving. People who work at heights, since it's a muscle relaxant, I mean it's better avoided. For painters who work at heights, you should be careful before you actually prescribe. Fatigue and body pain, again, because of pedal edema is a side effect that is really actually seen fairly commonly here. A lot of the times our experience with pedal edema is once it's there, it doesn't seem to be dose dependent, and we have had to actually stop the alcohol for the pedal edema to resolve. There may be urinary urgenance, incontinence. There is a lot of literature on risk of seizures with baclofen. But most of that literature comes from studies when it is used as a muscle relaxant in children with cerebral palsy. In our population, at least based on our clinical experience, we have not seen as many seizures. Probably with more than higher doses, the more riskier issue might be actually sudden stopping. So what happens is that when people use baclofen and they have a lapse, they suddenly stop, and because of the withdrawal and actually maybe some withdrawal of the baclofen, that might be cause even more risk of seizures than actually increased doses. There are also some studies here and there with baclofen induced psychosis. I mean, that's again a questionable entity. We are not really aware of the cardiac safety profile of baclofen at the doses that we use. So in someone with a comorbid cardiovascular disorder, it's better avoided is what I would advise. I mean, it's better avoided and use some other agent, because we're not really aware of the cardiac safety profile at the higher doses that we use. So these are some of the side effects that we should be. TOPIRAMATE is the other agent that we used at 100 mg to 200 mg. Can be used in patients with comorbid seizure disorder, migraine. So all of the agents that we have described. So as I said, I mean, NALTREXONE, 55 to 65 rupees for a 50 mg tablet. For a lot of our clients actually end up needing 100 mg of NALTREXONE. So that's around 120 rupees a day. BACLOFEN, generally 60 mg is the average dose that we give. That's one tablet of 10 mg BACLOFEN is somewhere around 10 rupees. That's 60 rupees a day that someone will have to spend. ACAMPROSATE tablets is somewhere around 7 rupees for a tablet. So somewhere between 28 to 42. So all of these medications are on the more expensive side. Comparatively to all of this, TOPIRAMATE is the cheapest among the lot. So that can be one of this thing. But I mean, the major thing is that people with alcohol use and long-term alcohol use may have cognitive. So behavioral and cognitive side effects with TOPIRAMATE are something very common. That those are something that there might be loss of weight, kidney stones. TOPIRAMATE has multiple side effects, so you need to be aware of these side effects. So okay, here we had a mechanism of action of DISULFIRAM. So I'll have a brief this thing about DISULFIRAM. This is also something that is commonly prescribed. It's an aversive agent. So the dosages that generally we give here are somewhere between 250 to 500 milligram per day. Without question, the cheapest agent. Written in bold, always take a written informed consent. A lot of the times DISULFIRAM is given surreptitiously. Never ever do that. Always take a written informed consent. You must take the patients. Do a liver function test. So I mean, DISULFIRAM may have hepatic side effects, so do a liver function test. It is very important for us to rule out any cardiovascular malformation. In the untoward event that someone uses alcohol and they end up having a disulfiram ethanol reaction, one of the major features is hypotension, and that might even lead to mortality. So in someone with any kind of cardiovascular comorbidity, do not use disulfiram. In somebody with family history of psychosis, so there is an entity called disulfiram induced psychosis. In some people who are vulnerable, disulfiram can actually induce psychosis. So we have seen people with disulfiram induced psychosis, people with disulfiram who have been given surreptitiously, who have ended up in catatonia, who have come to our clinic. History of neuropathy. So disulfiram-induced neuropathy is also somebody who's having alcohol-induced neuropathy or other neuropathy. It's better avoided. So these are some of the precautions that need to be taken. So who will you start it for? So somebody with good social support to maintain supervision that the person is taking, somebody who has commitment to abstinence, who is highly motivated and has an internal locus. So it's an internally driven motivation rather than more of external factors. So this is the patient profile. So in the correct patient, it's an excellent agent. So the thing is that, I mean, for us to actually elicit this information, it's not possible in one or two this thing with regards to actually finding out a degree of social support, the commitment, the motivation. I mean, it only comes after a few follow-ups, and we are more familiar to actually get all of this information. This is not information that we can actually arrive at in one. So that is the thing. In the right patient, it's the best drug. It can be actually combined with, so a lot of the times when we do use disulfiram, actually combine it with anti-craving agents as well. And it can be done without any of the precautions. When can you start disulfiram? You can start disulfiram 24 to 48 hours after the last use of alcohol. If somebody wants to restart using alcohol, you should ask them to wait for at least for 2 weeks before the last intake of the medication. So after the last use of alcohol, you can start disulfiram within 24 to 48 hours. But if somebody has been taking disulfiram for some period of time, you should ask them to wait for 2 weeks, because it takes around 7 to 14 days for replenishment of the aldehyde dehydrogenase levels in the body. So the other precautions that mild disulfiram ethanol reaction may happen with alcohol containing products such as shaving lotions, vinegar containing food products, your rum cakes. So all of those things must be. And with some other medications also, it might actually mimic. For example, with metronidazole, which is very commonly prescribed, cephalosporins are commonly prescribed antibiotics. So these are things, precautions that you must advise. And minor side effects may be drowsiness, headache, garlic-like aftertaste is what people do. Major side effects that acute hepatic side effects, neuropathy is something which is very common. Psychiatric complications is something that might happen. So these are things you must have before the faint idea of how disulfiram ethanol reaction. There may be facial flushing, sweating, mild headache, moderate nausea, tachycardia, hyperventilation. And what might happen is vomiting, there may be a cardiovascular collapse, hypotension, congestive heart failure. It starts within 5 to 15 minutes, lasts for 30 minutes to hours. The management is supportive. So generally when we prescribe, we actually take an informed written consent which is enclosed in the file. We actually give them a card, DISULFIRAM card, that they can carry around, so that if there is any instance they use alcohol, at least the treating person can identify that it may be because of disulfiram, whatever symptoms that are there may be because of disulfiram ethanol reaction.